It's now my pleasure to introduce tonight's speaker, Dr. Chris Walensky. Dr. Walensky is an Associate Professor of Dental Medicine and Director of Laser Dentistry at the Touro College of Dental Medicine. He's also a clinical principal investigator at New York Medical College. He's been an author, inventor, and educator in laser dentistry for over 2 decades now, and has authored a text on laser dentistry that has been translated into 10 languages. Dr. Walensky is the Executive Director of the World Clinical Laser Institute, or WCLI, and the International Dental Laser Research Institute, and is a founding member of the American Academy of Oral Systemic Health. He's a diplomat and a past president of the World Congress of Minimally Invasive Dentistry, and is a contributing editor to the Journal of Laser Assisted Dentistry. His fellowships include the International College of Dentists, the International Association for Laser Dentistry, and the American Society for Lasers in Medicine and Surgery. We are so pleased that Dr. Walensky joined us this evening, fresh off a plane from Barcelona, and it's my pleasure to introduce him to you this evening. Dr. Walensky, please take it away.
Thanks so much, David. Welcome, everyone. I'm not too jet lagged, so I think we'll be able to get through this pretty well. You said the Touro College of Dental Medicine, and up until recently, that's where I taught. Now it's the Touro University College of Dental Medicine. And for those of you unfamiliar, we are in New York. It's the newest dental school in the US, and it's about 25 miles north of New York City. So I would welcome any of you traveling here for, say, the Greater New York meeting in November. You want to stop by and see the most technologically advanced dental school. And I say that pretty confidently because it was a very strong factor in building this school, that they really wanted to have all the real cool gadgets and toys. Our students, they scan instead of taking impressions. They print their own models. They print surgical guides for implant placement. There we have, I think, over 30 Trio scanners for the school, and we have a bunch of BioLase lasers. So I'm real proud of what we're able to do there. And again, I welcome everyone, and thank you to BioLase for having me on and inviting me to this webinar. I do have to start with a disclosure that I don't really have any financial interest in any of the products that I'm going to be discussing today. And I'm basically going to be talking about one in particular, which is a BioLase laser, which is, I'm making some assumptions here, but I'll get into that in a moment. I am full-time at the College of Dentistry, but I do serve as a clinical consultant to BioLase. And anything that I present here tonight are my own thoughts, and that's probably what makes this scary. Anyway, some of the other things that I'm doing, I am currently the executive director of the WCLI, and I'm adjunct faculty or visiting faculty at a few other universities around the globe. And all of that is related to either minimally invasive dentistry or more specifically laser dentistry. So the school, actually, it says glass building here, and it used to be a building owned by IBM, and then the New York Medical College took it over, and today we just graduated our 3rd class. So the school has been in existence for only 4 or 5 years now, and 3rd class graduated. And so I want to congratulate any of those students who might be on here. But if I graduated today, I would not be on a webinar about laser dentistry tonight. So I don't expect anyone is there. The topic that we're talking about tonight, if you're new to this, it's going to sound like witchcraft and voodoo, but more so than if I was going to show you how to do a frenectomy or remove veneers off of your patients with laser energy. We're actually talking about using an invisible light. So there's no color to it. Some of the lights that we use do have some color, but many of them do not. And then a lot of what we're doing is not even generating heat that's discernible. And so, it's kind of like a magic wand. However, that being said, a lot of the things that we're doing, previously have been said, it's impossible. But this whole science has come out of veterinary medicine. And, when dogs and horses are able to ambulate properly after being injured, and birds are growing their feathers back again, and there's less pain, and there's less inflammation, and there's less swelling and faster healing, we know that there's not a placebo effect in mind. that being said, those of you who maybe have seen another version of this lecture, maybe it was a year or two ago, that's the last, I think that's the last time I'm going to mention an animal. So everything that I'm going to be doing here, some on the history, some on the background, but the kind of the meat of this lecture is going to be specifically, how can you use your laser to treat pain and inflammation and swelling? And I thought that would be probably the best use of our time today or this evening. So does laser therapy equal light therapy? What that means is that there are applications for lasers, obviously, in treating inflammation and pain, et cetera. But we can also do this with light, meaning that we can use a class 3B light as well. So it's more like an LED, and there's less harmful effects to our eyes. And why am I bringing that up is because the more and more this topic becomes relevant in medicine, and it's becoming that, especially personal experience in hospitals where they treat cancer patients, where they're dealing with oral mucositis. I can just go down the list of the number of hospitals that are now using light therapy and using these devices in order to treat children and adults who have oral mucositis as a result of chemo and radiation, especially to head and neck. And we're actually getting ready to embark on this same growing another hospital here in Westchester County, New York. And so it's just one by one, and they all look towards, you know, how does this work and why does this work? And the problem is that the more I personally study this topic, the more I realize I don't know about it. And that might sound silly, but there's so many confounding things. There's so many diametrically opposite effects of light, whether you're treating a healthy cell or a disease cell. And I'll get a little bit more into that in a moment. Whereas before we used to just say, well, you know, the laser is going to end up decreasing inflammation, end of story. But, you know, for instance, if we irradiate with a low-level laser, a photobiomodulation laser, a healthy cell, we can actually stimulate NF-kappa B, which is, it's been called like the actual switch that turns on inflammation. So if we have a healthy cell, we turn on inflammation, but if we have a diseased or a traumatized cell and we irradiate it, we can eliminate inflammation. And that's where this starts to get so confusing for me included, because it happens on multiple levels of different effects. The other thing is that, you know, we know that hard lasers are, you know, the surgical lasers. That's those the ablative devices we can do frenectomies or gingivectomies or biopsies. That's what a hard laser will do. But, you know, even when we talk about cold lasers and soft lasers, we can't even get together on the same page for that. And what do I mean by that? Because, you know, when we talk about low-level laser therapy, which is now photobiomodulation, we're talking about very, very low doses of light energy. However, as we increase, now we end up in the high level or high intensity level laser therapy, and they both have different effects on our tissues. So even that can become confusing. So that's kind of what I'm going to try to help diffuse some of this, this confusion. Another point of confusion, what is laser dentistry? I took this slide off of Google. This is laser dentistry. Actually, I took a page off of Google. If you look up here, it says laser dentistry. You look at these slides here. This is not, 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 is, this is not. So, I mean, most of these things are, you're going to either see a curing light, a bleaching light, or even perhaps, which is a laser, a diagnostic, like a diagnodent to diagnose caries in teeth. But this is not what we're talking about as laser dentists, but this is what our patients see. They Google laser dentistry, and more than half of these are showing curing lights. Well, their dentist is a laser dentist as well. So, you know, what's the big deal? And this is where we have to really start understanding where people are coming from and what they're understanding. Yet, if you go to other site, type in red light therapy, we just get pages and pages and pages of the beneficial effects of red light. And we have found out that red light, along with near infrared light, are the two wavelengths that really work well for photobiomodulation. And luckily, the laser we're going to talk about tonight has both of those wavelengths as part of it. So we'll get more into that specifically as well. So a little bit about the history. I mean, you may or may not have heard about this topic previously, but I can assure you that for thousands of years, there's all sorts of documented use of using light as a healing modality. This is a hieroglyph from Egypt. And if you go through these different ancient historical countries, China, for instance, used light as kind of like reflexology. Different colors of light activated different organs in the body and different functions. In Egypt, they equated it to different like earth and wind and fire, and we're not talking about R&B right now, but different elements. That's what I'm trying to think of. In India, they equate the different light to the 7 chakras in the Ayurvedic medicine. And so light therapy is not something that's new. There's even some writings from Hippocrates that on the benefits of using different lights. As we get closer to more recent history, about 100 years ago, Niels Finsen, he actually won the Nobel Prize in medicine for using the light to treat lupus vulgaris, which was at that time called tuberculosis of the skin. And you can see here where they used a Finsen lamp, which was a specific wavelength of light in order to treat this. And then as we get even closer to modern history, back in 1967, Andre Mester, was a doctor in Hungary who ran some tests where he had a group of mice. And so why would he do this? So back in that time period, 64, that's when lasers were actually discovered. Okay, that's when Theodore Maiman created the ruby laser. And then what's going to happen is that if somebody develops a device like a laser, you can imagine, well, let's see if it causes cancer. Remember, well, some people on this call or this webinar may remember when microwave ovens were invented. I remember this, and maybe you're not old enough to remember that. But the big thing was, anytime my mom turned on the microwave and she turned a little dial, it was kind of like, run for cover. Don't stand anywhere near the microwave. You're going to get cancer. And so as soon as she turned it on, everybody'd leave the kitchen until you heard the ding, and then we all came back and ate the food. But I would imagine the same sorts of thinking came about when lasers were developed. Like this, I mean, radiation is in the name of the device. It's, the R in laser is radiation. So, how dangerous is this thing? And so what Dr. Mester did was he took a group of mice and he shaved the hair off of the backs. Half of the group he just left as the control and just used a sham device. And the other half, he actually used a low-level device. And so he's considered the father of low-level laser therapy, because he decided and he discovered that the mice that he actually treated with the light grew their hair back like twice as fast as those that he didn't treat. So he actually was the one who coined the term biostimulation, which was kind of the precursor to photobiomodulation. But we do get biostimulatory effect in what we're treating. And then even NASA has used light out in space to test the effects of light and lasers in healing in space. And then we come up to present day. If your baby is born jaundiced, they use UV lights. If you have a pigmentation disorder, they also use UV lights in order to treat these dermatological psoriasis, vitiligo. If we go out of dentistry, and we'll come right back to dentistry, I only have one slide that's outside. Just look at the list of, and this is only a partial list that I put together of papers and evidence of being able to use light therapy in order to promote wound healing and tissue repair. I mean, it doesn't matter if this is outside of dentistry or not, we can use this. Improves hair growth in alopecia patients, carpal tunnel, diabetic foot ulcers, reduces psoriasis, rheumatoid arthritis. So any sort of inflammatory disease absolutely will help. Builds collagen to reduce wrinkles, helps mend sun damage, prevents recurring cold sores, improves joint health from degenerative osteoarthritis, and relieves pain and inflammation from Achilles tendon. And then there's others. I've treated personally patients with Bell's palsy with light. I've treated faculty members who have plantar fasciitis. There are multiple areas where we can use light therapy in order to help healing. And you've all seen this. If you have anything that, if you've ever been to a laser lecture, you saw two things. You saw a picture of Albert Einstein, and you saw this chart here of absorption over different laser wavelengths. And what I'll just tell you from this one is that anything below this line is not going to be absorbed at all. And then because it's because of the way the geometric scale, anything above this gets significantly more absorbed. And what we're looking for is lasers in this area. And what I'll go do is I'll get into the colors and the wavelengths in a moment here. But if you look at this slide here, a couple of things to keep in mind. Number one is that the green light, the green laser, these are both laser pointers, is 5 milliwatts. The red laser pointer is 3. So obviously the green one is stronger. It's almost twice as strong. But when you irradiate the finger, what you see, the green light is barely visible. It hits the surface and it doesn't really go through, whereas the red one's making the finger glow. The reason for that is that we're getting so much higher absorption of the green light into the blood in the finger. So it hits it, it gets absorbed, and there's really no transillumination. Whereas if you look at the red, we're getting a lot of scatter, a lot of refraction, and then we're also getting backscatter. And what the backscatter is you can see how bright these fingers are lit just from the laser light that's going into the finger. So that's one of the reasons why we're using the red wavelength, because similar effects happen in the tissue, and also similar effects happen with our near infrared light. So what is near infrared, far infrared? It's once we get to the right of this this visible light wavelengths, especially the red, we start getting into the near infrared, and then the further and further we got farther and farther, it becomes far infrared. But what we notice here is that instead of absorption, what we're seeing in this chart is actually the depth of penetration of these different wavelengths. And so if we look at these, we can see that, let me go back here for a second. If we go out here to the erbium laser, which I know a lot of you are using erbium YAGs or erbium chromium YSGG, we know that the depth of penetration is very superficial. In other words, if you took a sheet of just plain paper and sliced it into 10 slices, the depth of penetration is approximately the thickness of 1/10 of a piece of paper. So that's not particularly helpful for photobiomodulation. But when we get into using diode lasers and visible light lasers, that's when we start getting into the tissue, and we can actually have a very suitable effect into the tissue. There is something called an optical window, and what this means is that these are ideally the best wavelengths to use for photobiomodulation. And what we see is that it encompasses red light, which red goes from about 600 to maybe 700 nanometers, and then it goes into the near infrared. But there is also this band between about 700 to 770, which has not been shown to be particularly helpful. That really doesn't affect too many lasers and too many doctors, because there aren't a whole lot of 750 nanometer diode lasers. You're usually, you have the aiming beams, which are 630 and 660, which pretty much everybody's laser has some sort of an aiming beam. Some of them are green, but most of them are red. And then once we get into the diode lasers up to usually about 1100 realistically, that's where our lasers are going to reside. So if you can combine these lights, meaning that if you turn your aiming beam on, maybe you're like me and you turn your aiming beam off whenever you use your laser, this is an opportunity to use your aiming beam, because it can, instead of being just an aiming beam, it can be a treatment beam when we're talking about photobiomodulation. I'm going to skip that slide. Sorry about that. So essentially what we're talking about is using a form of light therapy that utilizes non-ionizing, obviously, light sources, including LEDs and lasers, and it's in either the visible spectrum or in the near infrared, and it can alter cellular function. And it happens on kind of a cascade, meaning that there's multiple effects that happen when you irradiate tissue. And this has actually even gone to the point where, this may look ridiculous, but they've been using this to treat depression and traumatic brain injury, along with Alzheimer's and Parkinsonism, with the nasal cannulas and the actual helmet on the head. And they're using LEDs, not lasers, in order to irradiate brain, in order to stimulate brain function. So this is something serious, and it's become quite common in medicine at this point. So if we look at, this is from a book that was published quite a while ago by Jan Tuner and Lars Hodes, and this is part of the cascade of events. And this was what we knew back then, as they say. There's back then, and then there's now, and then there's a whole progression of things that happen. But yeah, there's a release of endorphins, and so we get the body's natural morphine to get activated. There's formation of ATP, which ends up being a big part of this whole formula, and I'll explain that a lot more in detail here in a moment. We get metabolism and proliferation of cells, and then there's gene transcription, where the DNA and the RNA in the cells actually it's a tertiary effect that the DNA and RNA in the cells actually can be affected, and then it can affect immune system function, and then typically it will reduce inflammation and edema. And as you know, kind of subsequent to that, a lot of times pain is caused by edema. And so if we can eliminate the edema, we definitely decrease the pain as well. So the effects in the mitochondria are really what we're going to talk about here. And most of this work was, a lot of people did it, but the first person that really came out with a good understanding of it was Dr. Tina Carew, who's a biophysicist in Russia. And so some cells, you remember this, right? They're the powerhouses. The mitochondria are powerhouses of the cells. Some cells have thousands of them, depending on what they do. Some cells, like a red blood cell, don't have any. But there's an outer and an inner mitochondrial wall. And in the inner, oh, I'm sorry, one more slide I slipped in here, and this is all from Tina Carew. But so in most cases, the final, and this is back in '87. So this is kind of where we were, and some of this is still accurate, but I think some of it is a little bit dated. The final photobiological effect only depends on the radiation dose and not the intensity and the exposure time. And I would say that probably, I bet you 100% of the papers now talk about the importance of the intensity of the light, where you don't want to have it too strong. And then the exposure time is also very important. You don't want to have a huge blast in 1 second, nor do you want to have to use such a low amount of power over 45 minutes. There's a happy medium in between there. The biological responses of the same cells to either pulsed or continuous light of the same wavelength, average intensity and dose can be different. So it depends on what you're trying to treat, and it also depends on healthy or diseased tissue. The irradiation effect depends on the physiologic status of the host organism. And then precise and statistically significant effects of laser radiation could be recorded only in the periods of acute illness, meaning that if you have healthy tissue, so if there's practically no effects of laser radiation when the blood of a healthy donor is irradiated. Whereas you can irradiate the blood of someone who's ill, someone who has inflammation, especially in their long bones where they have a lot of marrow, big marrow spaces like their femur or their sternum, and you can see effects throughout the entire body, positive effects on inflammation. So I threw that in between here. So I showed you a picture of a mitochondria, and I was talking about the inner mitochondrial membrane. And that's where something called the electron transport chain happens. And you remember this, I'm sure, just like you remember the Krebs cycle and how to draw out all of the amino acids. So what we're talking about here is that, this is the production of ATP. This is the production of the energy in the cells. And the reason that I highlight some of these things is that I'm going to show you photosynthesis in a moment, and you're going to see the same sorts of chemicals being manipulated by light. So during times of stress and trauma, disease, cells, just like our core, end up trying to protect themselves as far as there's no proliferation going on. It's just protection of the organism so that it doesn't cease to exist. And during those times, you're not getting, or you're getting very little production of ATP. We're not in a proliferative state. We're into a protective survival state. And so one of the things that will happen is that you end up getting a buildup of nitric oxide. And the nitric oxide acts very similarly to nitrous oxide. So we all know what the effect of nitrous oxide, right? It binds to the receptors competitively against oxygen. And that's why after you've treated a patient with nitrous oxide, you have to run 100% oxygen through them for a few minutes in order to reestablish the oxygen to the receptors. Nitric oxide reacts very similarly, whereas before this oxygen was being used in order to create water, and then water with ATP synthase actually creates ATP. That oxygen gets displaced by nitric oxide. And so now what's happening is that we're limiting the amount of ATP that's being produced. The other thing that happens, and this is kind of, this can be confusing because in healthy cells and in unhealthy cells, the light has a different effect on creating reactive oxygen species, and it also has to a different effect whether there's high levels of reactive oxygen species versus low levels on what exactly is happening. But if you have a high enough level of these ROS building up, they can become toxic. But even on the lowest level, they increase inflammation. They premature aging, that sort of thing. Free radical damage. That's part of the reactive oxygen species. So what happens is that when you can match, and this goes back to Tina Carew again, when you can match a particular wavelength of light, which is typically that near infrared, with the tissue that you're treating, it will disassociate that nitric oxide, and you'll end up being able to, the process creates, reproduces, and then you're ending up being proliferative again. And that's why the very last bullet on that previous slide said that if you treat unhealthy tissue, you're going to notice big effects. This is what happens. You notice these big effects because we're increasing vascularity, and then we're bringing in all of the growth factors and increasing ATP, and that's how we end up getting healing at one effect, at one point in time. If we look at what we just saw in a mitochondria and compare it to what we accept as fact in photosynthesis, what we're looking at here is in a chloroplast, and the size of the chloroplast and the mitochondria is about the same. The chloroplast is a little bit fatter, but other than that, they're the same length. They have very similar. You activate light, and NADP ends up becoming NADPH, and then you're getting ATP. So you have a very similar effect. So these are biologic tissues. And we have no question in our mind. I don't think there's anyone on this webinar that would question that. If plants need light, we also need light, and it also does the same sorts of things where it stimulates the immune system, it increases lymphatic drainage. We end up positively affecting the histamine response. Growth hormones increase. The body's natural healing processes are enhanced. So, as they say in a nutshell, there's a lot of very positive effects. So what areas of the body does this work with? And there's three primary. Number one are sites of injury. So when you have pain somewhere, we can use this light therapy in order to treat that. Secondarily, we can treat nerves, and then we can also treat trigger points. So, most of us, I know people are coming from all over the world to this. Some of you have learned trigger points in dental school or medical school. We don't learn that here in the US. So thankfully, there is actually a trigger point flip chart. It's by Travell and Simons. I think it's about $65. It's a big book, and you can open it up and actually learn where the trigger points are, and you can treat those specifically depending on the areas that you want to treat. I would think that most of them are going to be on this left slide here, but if you want to treat carpal tunnel, or you want to treat your son's soccer injury, or you twist your ankle or something like that, you have hip pain, we've treated all sorts of things for ourselves and our families, but those are primarily the three areas that we're going to treat. Another way that we can use this, I don't have a ton of, because historically, when I've given this lecture, I've gone through 40 different dental applications. I'm just going to show you this one, and later I'll go over some CMD. But what we have here is a study that was done in Ankara, Turkey, and these are 4 patients who had third molars removed. And sorry, okay. I'm sorry. 4 patients who had third molars removed. They were all female patients. And then a period of, they were all between 21 and 26. And they were treated between 12 and I think about 1 and 2 years post-surgery. They all had long-standing paresthesia. And all 4 of these patients resolved after having photobiomodulation treated. And typically what you'll do is treat intraorally and extraorally, but it's a lot of treatment time. There's something like 26,000 or 36,000 joules of total energy, which may not mean anything to you right now, but once we start getting into some examples, it's going to mean quite a bit to you. So the 4 female patients had complaints of paresthesia for at least a year, and low-level laser therapy seemed to be conducive in the reduction of long-standing sensory nerve impairment following third molar surgery. And this works with those same wavelengths, the red ones, and then the near infrared, specifically near infrared between about 800 and 1,000. So any of the 808, 810, 940, 980, those work very well for this. So we're talking about light, and I'm talking about it as if it's a drug, and that's actually how we can we can dose light. And so there's something called a biphasic dose response, meaning that this is normally used in pharmacology, where a little bit's good, a little more might have some negative effects, and a lot is going to kill you. And so what happens is that it's not exactly the same, because you're not going to kill any of your patients from using low-level therapy, photobiomodulation. But if we look at, say, the treatment effect here as this red line, at one point, and this is the joules per centimeter squared. So this is the dose that you're treating with. At the beginning, you're not going to be treating with enough energy to do anything. There won't really be any effect, right? So you have to increase the power that you're using. And then you do end up getting an area where you have a therapeutic effect. And that's typically somewhere about 50% of this, 50% up this curve is where you're ideally going to be. This chart has been modified from the ones that normally show about 1 joule per centimeter squared, just because what most of the papers have found is that the therapeutic dose ends up being somewhere for low level 2 to 5 joules, or maybe 4 to 8 joules per centimeter squared. Those are kind of the ranges. And then once we get to high level, it's 10 or 15 joules per centimeter squared, or even higher. I've actually personally even used a lot higher than that. But what this means is that you get to a point where it's ideal, which let's say it's, in this case, it's 5 joules per centimeter squared. What that means is that that's the total dose that you're treating with. So you need to deliver 5 joules per centimeter squared, and I will explain how to get to that number. And once you treat that, sometimes it's each point you treat 5 joules per centimeter squared. Sometimes it's a single point, depending on what we're treating. I'm sorry, I was told to check my texts. Okay. And it depends on what we're treating, and it depends on the paper that you read. And I'm going to show you how to decipher these papers. But what happens too is that once you get to a certain point, the healing effect, the therapeutic effect of the laser starts to acquiesce, and you end up getting more of an inhibitory effect rather than a healing effect. So what does that mean? It means that if you're in the 2 to 5, let's call it yeah, five, whatever it is. Some people say 2 to 5, some people say 4 to 8, somewhere in that range from 2 to 8 joules per centimeter squared of total dosage, you're going to get healing. And once you get higher and higher and higher than that, let's say, and typically, just to give you an idea, that's normally somewhere around 0.1, 0.2, maybe 0.3 watts using the pain therapy handpiece. So I've just put this into perspective for you. That's not a lot, right? I mean, when you're doing a frenectomy, you're probably at like 2 watts or maybe 1 watt, but now we're down to just fractions of a watt in order to get that, that dosage. Once you start going up to say 3 watts, 4 watts, 5 watts, 10 watts in order to treat, now we're in a totally different area, and we're actually can inhibit the healing effect. However, what we do is not just inhibit healing, we can inhibit pain transmission. And what happens in that case is that at higher levels, so we go from, remember I said that there's so much confusion, there's low level and there's high level. We transfer from low level where we're healing to high level where we're causing pain reduction. And part of the mechanism of this is actually inhibiting, because we're talking about inhibition, inhibiting some nerve transmission. And typically the nerve fibers that are most affected are the C nerve fibers and then the A delta nerve fibers. And the reason for that, if you remember, you don't remember, C nerve fibers are not covered by the Schwann cells, the myelin sheath. There it is. It's not covered by the myelin, and A deltas are also lightly covered. And so what happens is if you do get a lot of that lipid coating on the nerve, which actually helps transmission, it will actually keep the laser from working too well. And that's one of the reasons that one of the effects of non-dental treatment is treating abdominal fat with the laser in order to decrease inflammation and losing some of that fat. So low level healing, high level pain reduction. Okay, I'm just put this in here as an example. This is the one you normally see where it's we've shifted it from, actually I didn't shift it, Mark Cronshaw and Stephen Parker and that group, Eugenia, ended up shifting it over to 5 because that's really where it belongs. The other thing is that all of this is actually from 1888. And so the reason I point that out is that a lot of times you see the Arndt-Schultz phenomenon or the Arndt-Schultz law, and it's purported to be about lasers. And it clearly isn't. It has to do with the biphasic dose response. And this is just pointing out the area that we're getting probably the most effect, which I particularly like 4 to 8 joules. And this is just an example from a paper published in 2011. And this is particularly about ATP production as a function of the amount of energy that you're using. And you can see that the higher you go up to about 3, somewhere around 3 joules per centimeter squared, you get the maximum effect. And then as you get higher and higher, the positive effect starts to decrease. And so, you would think, and a lot of times we think this way, well, if a little is good, a lot's going to be great, and that's not necessarily the case. Okay, so fluence and irradiance, and there's even this is there's some confusion about it. And so in photobiomodulation therapy, when we talk about fluence in joules per centimeter squared, that is the total dose. When we're talking about using an ablative laser and we say Fluence, that's what we're actually, that's how much laser energy is coming out of our handpiece at the time. So we have to forget about that for right now, because Fluence sounds like fluid. It sounds like something is moving, but in photobiomodulation, it is the total dose per unit area. It's directly related to the power density, which is watts per centimeter squared. And then in order to get the power, you divide the power by the spot size, and that's how you get the power density. And so this is the handpiece for the EPIC or EPIC 10 or EPIC X laser. And this is where I'm making an assumption. We're doing this for BioLase education. So I'm assuming that those on this call are, you have access to this laser. So I'm going to speak specifically to this and not to any other device at this point, hopefully to help you understand how it works. So we have the handpiece, and then we have these marks along the handpiece. And what that means is that you can actually click this spacer, that's a spacer, this plastic thing here. And if you can imagine, if you go down to here, then this part will be a lot closer to here, and it will actually create a 15 millimeter spot size. So it has nothing to do with how far this is from there. When you put the laser down onto the table, it will create a 15 millimeter diameter spot size. You put it here, it will create 20, here's 25, and here's a 30 millimeter diameter spot size, meaning that you'd move this spacer down to this point. This will get farther away from the actual beam, and your beam will get bigger and bigger. This is one of the ways that you can titrate the dose that you're going to treat your patients with. If I'm treating intraorally, I always remove the spacer, and I will put a plastic bag over this, the same type of bag that you would use for maybe an air water syringe or for your high-speed handpiece, or the same bags that you use. That way I can use it in contact, because I know the exact amount of energy that's coming out of here. Once we start to move that tip farther and farther from the tissue, I know the spot size, but I don't really know exactly how much energy I'm delivering. And why is that? Because the tip is now significantly farther away. The tip is probably, I don't know, in 2 inches away from the end of the spacer. So we also now have to account for more reflection, and we also have to account for beam divergence. And I don't know about you, but I'm not a laser physicist, and I don't have a power meter at my disposal everywhere, every time I go into the treatment room. So at this point, I'm going to concentrate more on being able to use this tip in contact. What I will tell you is that you obviously can use it with the spacer, especially if you want to treat larger areas, but you're going to have to account for the fact that the actual laser beam is coming from farther away. And because it's farther away, you remember power density and spot size. When the spot size is small, the power density is high. So that's what you're going to get at the very tip here. But as soon as you move away and it starts getting bigger and bigger and your spot size becomes much larger, your power density decreases significantly. And as I said, you're also going to get some refraction. You're going to get a lot of reflection off the tissue. You may get some more absorptive effects, whether there's hair there, the color of their skin, the Fitzpatrick scale, everything comes into play, and it becomes a really messy formulation. And also remember that this is not a flat top beam. This is a Gaussian beam, meaning that the energy coming in the center is a lot stronger than the energy coming from the periphery. So that's another reason we can't get exactly we won't know exactly, that's what it is, how much energy we're delivering over an area. We're going to have to take our best guess. So let me just show you this. This is a paper that was, when was it published? 2021. I tried to pick something that was fairly recent. And this is photobiomodulation and myofascial TMD. I can't see behind here. Systematic review and meta-analysis followed by cost-effective analysis. And basically they say that it's a lot more cost-effective. And so take a paper like this. This, I liked it because it was a systematic review and a meta-analysis, which gives us a whole listing of papers, and they've done the work of sorting through them. meaning that their initial search brought up 316 papers. And then once they got through the systematic review, they got 17 papers. So 17 is a nice number for us to look at. And this is a partial listing of those papers. I just took a screenshot of them. And it tells you that they're diode lasers. That's what the gallium aluminum arsenide lasers are. It tells you the amount of energy that was applied in these patients. And this is all for TMD. So let's say you're looking for TMD. It gives you the wavelengths. It gives you the power that was used, how many treatments. So what this looks like is they treated over 4 weeks, 8 sessions. So you know that they treated twice a week. We have 3 weeks, 9 sessions. So you know they treated 3 times a week. What I will tell you is that you can treat up to every 24 hours. It's just that it's difficult to get a patient to come to your clinic every 24 hours. And it's hard for me to find an open chair every single day to be able to treat somebody for TMD. So that's why normally protocols are between 2 to 3 times a week until the patient resolves. The results of this paper show that there's 2 different, and you'll recognize this now, 2 different levels that the doctors used, that the researchers used. And the 5 to 7.5 joules, this all falls within that 4 to 8. This is for low level for healing. And then some of the papers are between 25 and 60, which is high level. The reason I've highlighted 5 and 60 is that I'm going to show you, if you want to treat someone for pain using the EPIC laser, I'll show you how to figure that out. And if you want to treat somebody for healing, I'll show you how to figure that out. So if you measure from the actual output here, you get 1.2 centimeter of diameter. Now, I've read and I've seen presentations where they describe the surface area of this laser to be between like 7.1 to 7.9, I'm sorry, 0.71 to 0.79 centimeters squared. But I'll show you why that's not accurate. This is looking directly at the end of the laser. Never look at the end of the laser. So what you see here is that this is the actual window. This is the optical window, and it's 0.75 centimeters. But thing is that window compared to this edge right here is 5 millimeters deep. So what that means is that you cannot put this window directly onto the tissue, can you? Because you've got 5 millimeters, and then it comes out to this measurement. So the closest we can get is 1.2 centimeters of diameter. We can't use the 0.75. So that's why we have to be able to use 1.2 centimeters instead of 0.75. And that changes a lot of people's calculations. So this is my explanation for that. So at 1.2 centimeters, we'll do the math for you, but it'll come out to like 1.13 centimeters squared. So normally patients come in for TMD for pain, right? They're not going to come in and say that they want healing. I want you to heal me. Normally they're having some sort of pain that's related to their joint. We're going to use the 60 joules per centimeter squared because that was in one of the papers. And so what we need is to figure out, we know the total dose because that's what the 60 joules per centimeter squared is. We're treating with 60. And we also, we know the size of the aperture. We know the spot size, not the aperture, but we know the spot size of the laser. So we also need to separate the time component. We need to know how long to treat, and then we need to know how much power that we're going to end up using. So you've already seen this part of the explanation. So the total energy to be delivered is 60. The spot size is 1.2 centimeters diameter. We know that pi r squared is the formula. So we end up coming out with 1.13 centimeters squared. So that's the size, that's the area that we're going to end up using laser energy through. So we're missing power and we're missing time. And those are really important. And the other thing to keep in mind is that, that a lot of these papers, they don't deliver either accurate figures because they make errors, and they don't deliver all the information. Sometimes it's like when you ask your grandma for her cookie recipe and she leaves out, baking powder or something that's pretty important, and your cookies never come out quite the same as hers, it's the same sort of thing. If you don't have all the parameters, you're not going to be able to get the same sorts of results. What I will tell you is that after reading lots and lots of papers, we try to aim for somewhere between 30 and 60 seconds. That's a reasonable amount of time. If we have to go to a minute and a half or 2 minutes, it's not out of the question, but you don't want to have to treat someone for 1.3 seconds or for 45 minutes. And obviously I'm exaggerating, but you try to keep it somewhere within about 30 to 60 seconds per point that you're treating. So we go back to what I just showed you there. We're going to treat for a total of 60 joules, and we know the area. How do we figure the other two things out? Let's start with 60 seconds as the time. Just, you read the paper, let's see what 60 seconds does. And we know it's 60 joules, 60 seconds, we're going to deliver 1 joule per second. It's a pretty simple formula here. So we're going to deliver 1 joule per centimeter squared per second for 60 seconds. We're going to get 60 joules per centimeter squared. We also know that by the definition, 1 watt is a joule per second. So therefore, we're delivering 1 watt. So we know that in this particular case, we're delivering 1 watt as long as our spot size is 1. However, our spot size is not 1, it's 1.13. It's a little bit bigger. So what do we have to do? We just have to multiply our 1 watt per centimeter squared times 1.13, and we end up with basically 1.13. So 1.1 watts for 60 seconds. But I don't know about your Epic laser. My Epic laser doesn't go to 1.1. So we have to figure out how that we can change the time in order to make this exactly the right time. So in this example, we can either do 1.1 watt for 60 seconds, or we can double it, 2.2, or maybe go to 2.25 for 30 seconds per spot. And that's how we're going to figure that out. And then we know the power density, and the power density comes out to almost 2,000 milliwatts per centimeter squared. What I will tell you is, as a rule of thumb, we like to stay about 100 milliwatts in that area. Maybe not ideally, if you're a purist, pure PBM purist, you'll stay at 100 milliwatts, but a lot of times there's a little bit of room for wiggle. So if we go to the second example, and I'll explain a little bit more. I know I haven't actually clarified that, but I want to show you the math real quick here. Same thing, 5 joules in the same area. How we're going to find it? Basically, you're going to take 5 joules, divide it by 60, and that comes out to 0.83 joules, or 83 millijoules. Same thing, or per second over 60 seconds, and you get 5 joules. Therefore, we want to try to get 0.83 watts. Well, again, I don't know about your laser, but I can't get 0.83 watts out of my laser. So we multiply by 1.13 centimeters, and we get about 0.1 watt. And if we do 0.1 for 60 seconds, that's going to give us our 5 joules per centimeter squared. I'm running out of time, and I'm probably going a little bit fast. I'm sure this is going to be recorded. You're going to be able to get these slides again. So about 0.1, which you can do 0.1, you can do 0.1, you can do 0.2. And those are typically, when we go to the pure PBM settings, those really are the settings that we're going to use, 0.1 or 0.2 over a certain period of time in order to get what it is that we want. And we notice that when we look at the power density, remember I said you try to stay at 100 milliwatts or thereabouts, we're at 90. So this is a perfect setting for doing healing with PBM. So the confusions, as I mentioned earlier, is that Fluence has 2 different definitions. It's reported in joules per centimeter squared for laser ablation, and then the total dosage is also Fluence, but that's for PBM. It's also joules per centimeter squared, but it's 2 different explanations for what Fluence is. Power density is also called irradiance. It's reported in watts per centimeter squared. And sometimes you'll read a paper and it'll say the total dosage is joules. But what they mean, I think, is joules per centimeter squared. So based on the, let me go back here for a second. Based on the current recommendations between 4 and 8, I've done the math for you. So 4 joules per centimeter squared. The actual calculation for your handpiece is 0.7 watts for 60 seconds. But again, 0.7 watts is such a small amount that we can't possibly get to there. So what we end up doing is we use 0.1 for 45 seconds and we get the same amount of energy. For 5 watts, 0.1 for 50 seconds, we get the same amount of energy. 0.1 for 60 seconds, we get the same. 7 joules, 0.2, I keep saying the same amount of energy. I don't mean that. Here you're getting 4, here you're getting 5, here you're getting 6, here you're getting 7, and here you're getting 8. So if you were going to take a picture of a slide, this might be a slide that you'd take a picture of right now, because these are the settings that you will use in order to achieve 4 to 8 joules per centimeter squared, which most of your papers are going to explain to you. The other consideration is, how deep are we treating? You know, are you treating a free gingival graft and you're just going on the surface, or are you trying to treat a TMD that's a little bit into this tissue? And then you have, you know, what's between there? There's joints, there's ligaments, there's muscle tissue, there's skin, there's reflection. How far from your surface is your actual probe? That's why I like to use the plastic bag and put it right onto the surface of the tissue. But there's a lot of effects that are a lot of things that can affect the amount of energy that we're using. And then there's this paper that it's like, oh my gosh. So mathematical simulations and estimates suggest that the laser can go about 2 inches deep. However, what they did was they took humans' abdominal skin samples, probably from somebody who was having lipo or something like that, and up to about 0.8 millimeters in thickness. So it wasn't even a millimeter in thickness. It was less than a millimeter in thickness. And what they found was that the intensity of the laser radiation reduced by 66% after being transmitted through a 0.8 millimeter sample of human abdominal tissue. So according to this, most of the radiation is absorbed within the first 1 millimeter of skin. And I know that, you know, non-vital skin is going to react different than vital skin, but this just does give you something to think about. All right, we did all of these fancy calculations and now you've got 1.1 for 60 seconds. Is that even going to do anything? And so I think where we're headed is, even though we have the low level people on one side and the high level people on the other side, I personally think we're going to have to come together and use a higher level of power or a higher level of energy and end up getting analgesic effect closer to the surface and getting healing effect as the laser level of the laser attenuates as it goes deeper into the tissue, so that we get both, because otherwise you may not have enough energy to penetrate the tissue. So this I've shown you already. This I'm going to skip. And this is, okay, so the last couple of slides here. In order to treat TMD, this is one study where they had 58 patients, and they tested their maximum mouth opening, which was very limited. And then they decided that low-level therapy could be an alternative physical modality or supplementary approach for the management of acute and chronic myogenic temporomandibular joint disorder. And so what the important part here is that they treated 8 joules per centimeter squared, which you now know that's the total dosage, right? And 12 sessions. 12 sessions, I don't remember whether it was like 4 weeks, 3 times a week, or if it was 6 weeks and twice a week. Either one of those would probably work. I'm sure that they would work. And so you can kind of, if you read this paper, you can figure it out. But I would tell you that if you have time in your schedule to do it 3 times a week, that will be more effective than doing it twice a week for 6 weeks. And then finally, you know, where do we treat? Well, most of these papers will give you kind of specific areas that they will treat. But in general, what I will tell you is that the points that you're going to treat are typically temporalis, masseter, and then the actual joint. And you'll spend the same amount of time on each of those. And sometimes you'll actually go down the neck and even treat down to the trapezoids. And it really depends on what it is that you're trying to accomplish. And so normally, you can see treatment of painful regions. This is for pain. We're going to use a higher power. We're not going to use 0.1 or 0.2. We're going to use a higher power in order to treat the pain. And I've seen regimens that go as high as like 7 watts in order to treat this. As long as the patient is comfortable with the temperature of the laser, you keep the laser moving. I've personally treated patients with this, and not only do you get the high level effect of the laser works very much like an infrared light, which is, have been used for longer than lasers have, in order to get a localized increase in tissue temperature. So you're going to get pain reduction just having it act like an infrared device. If you have more interest in this topic, there are other books. These are all by Michael Hamlin, who is one of the most sought after, foremost experts on this topic. He teaches at Harvard University in Boston. These are some other authors that have done a lot of work in this area. Tina Carew is the one who figured out what's happening inside the inner mitochondrial membrane. Roberta Chow, Jan Bjordal, Praveen is now at the University of Buffalo. Cesar is at the University of Florida. Renee Jean is in France. There's just a tremendous amount of resources for you if you have questions. And of course, you're going to have questions because this is a very confusing topic. But basically, the consensus of every single paper that you read is that further animal and human studies are needed to determine the optimal timing and dosage of PBM for whatever it is that you're trying to treat. So I thank you very much for your time, and I really appreciate, again, BioLace for hosting this webinar. If you have time, I have time to stay for some questions. Thank you very much.
Yes, thank you, Dr. Walensky. And even though we are just a minute or two over, there is one question, so we certainly can get to that one. It's from Dr. Shimizu. And the question is, can dosing be based on immediate pain relief rather than calculating joules per centimeter squared? PBM requires multiple application. Is there then a consumer PBM unit that can be applied by the patient?
Okay, so for the first part of that question, absolutely. Every time I treat someone who has pain, I've treated lots of different things, but let's just keep it for joint dysfunction at this point. You can use, as long as if you have, there's kind of complicated. So if you have a laser that only does PBM, you're not going to get that pain reduction, because those lasers typically operate in milliwatts. And so you're going to be using 50 or 100 milliwatts per centimeter squared, and you won't get that pain reduction. If you use something like the Epic laser or the Epic laser, you can dial it up, and every single time I do it, I get the same response from the patient. They're able to open wider, because maybe we'll measure the intra-arch distance that they can open, maximum distance, and then right afterwards they can open another 10 millimeters, and they always say the same thing. They say, I don't know if it's just me, but I think it feels better. And so they're usually incredulous, because how could this light have done that? But you can absolutely get immediate response. The thing is, it's more of a 2 steps forward, 1 step back, 2 steps forward, 1 step back. So that's why you have to do multiple treatments, and patients need to understand that. And you need to, if as far as charging patients, you need to charge them for a series of treatments. And there aren't lasers that patients can use on their own, but there are class 3B devices, LEDs, that they can use in order to treat themselves. In Japan, there's actually sections in the pharmacy where you can buy a laser, or you can buy a red light device.
Excellent. Thank you very much, Dr. Walensky. I don't think we have, well, let me see. There's some new ones that just came in. Hang on 1 second. Are you aware of, both from Dr. Silver, and I think these are quick, so let's go ahead and wrap it after these. Are you aware of any studies for EDS patients? And the second question is, do you ever use the pain wand with the spacer?
You just got another question. I need Dr. Silver to, I don't know what EDS is. I'm sorry. And then, do I ever use the pain wand with the spacer? At this, you know what? I used to at the beginning. I don't anymore, because I typically kind of have some settings in my head for what I'm treating and what's been effective in the past. So I'm not saying don't use a spacer, because if you use that, what is it, 1.2 centimeter diameter tip close to the tissue, it's going to take you longer to treat because you have such a small spot size. If you can get it to 25 millimeters in diameter, you're going to be able to treat. You put a higher setting on the laser, and then you can treat it a lot faster. So depending on what it is that you're treating, absolutely you can use the spacer. The thing is that a lot of what I treat is intraoral, and when I use it intraorally, I can't fit all of that thing inside the mouth usually. So that's why I take the spacer off.
Okay, thank you. Dr. Walensky, just out of respect to everyone, we're about 6 minutes past. There are a couple more questions. What I might suggest is Dr. Walensky's contact information is on the slide there, and he is very good at email. I know this even when he's traveling in Europe. So he's thezendoc@gmail.com. I would suggest if you had a follow-up question or I wasn't able to get to one, please do send him a note there, and I know that he would be happy to respond.